we have a very interesting session on GAPIO IST International Lecture Series. I welcome all of you to this wonderful session where gastroenterology topics are being discussed by eminent gastroenterologists and which is quite useful for the general practitioners and non-gastroenterology specialists like physicians, surgeons, gynecologists, pediatricians. Because we bring in new things which are less discussed in the common forum, and this is yet another session for that. Today we have very interesting group of people and two important lectures. And may I welcome myself. I am Mathew Philip, the Secretary General of Indian Society of Gastroenterology, and I thank the Global Association of Physicians of Indian origin to associate with the Indian Society of Gastroenterology for this interesting webinar series. So may I request Dr. Ramesh, who is a senior consultant gastroenterologist as well as HOD of medical gastroenterology as Sleeva, Medicity, Palai, Kottayam, Kerala. He is also currently the Secretary General of Kerala chapter of Indian Society of Gastroenterology. Welcome, Dr. Ramesh. Can I request you to start the proceeding with introduction of Dr. Shibi?
Thank you. Thank you, Dr. Mathew Philip. Am I audible?
Yes, you are.
Yeah. So, very warm good evening to all. It's a wonderful evening. And at the outset, I would like to thank GAPIO IST team for giving this opportunity to me. Today, we have two interesting sessions and two very enthusiastic speakers also. It's a very common topic, the management of variceal bleeding and MASLD management. So, to start the proceeding, I invite Chairperson, Dr. Shibi Mathew.
Thank you, Dr. Ramesh. Good evening to all from this part of the world. First of all, let me thank IST and GAPIO for giving this opportunity to me to be part of this great program. I must congratulate the leadership of IST and GAPIO for providing such a wonderful platform of interaction between experts around the world. So as Dr. Mathew Philip has already described, today's program includes two topics, that is two topic discussions, and this will be delivered by two eminents in their respective fields. So the program continues like initially we will have a first topic presentation. This will be followed by the second topic presentation, and at the end, that is for 15 minutes, we will be having a question and answer session. So I request all the audience to type down your queries in the chat box so that we can discuss these queries at the end of both the presentation. Please note that we'll be having the discussion at the end of both the presentations. So without much delay, we will proceed to the first session. First topic is management of variceal bleed. As you all know, the research in hepatology is progressing at a faster pace nowadays. So each year we are getting more insights into the pathophysiology and management of variceal bleeding. So to talk on these various aspects and which are the newer guidelines which have come up, we have Dr. Ashok Jhajharia, who will be talking on the topic of management of variceal bleed. So he is an associate professor at the Department of Gastroenterology at SMS Medical College, Jaipur. He has published over 50 research papers in various Indian and international journals. He has pioneered the use of coil and thrombin along with the gel form in EOS-guided targeted obliteration of gastric varices and pseudoaneurysmal bleeds. Also, he has secured a funding from ICMR and currently is doing a molecular study on pancreatic cancer genotypes in EOS-guided FNAC tissue acquisition. Over to you, Dr. Ashok.
Before that, let me introduce Dr. Shibi Mathew, who is a wonderful gastroenterologist from Kerala, and he is into endoscopic ultrasound, and he is he's a senior consultant working at Lisie Institute of Gastroenterology, Hepatology and Transplantation at Lisie Hospital, Kochi, and he is also the Chief of Academic Affairs of Gastroenterology Department at Lisie Hospital. Thank you, Shibi, for joining, and I am sharing the slides of Ashok. Ashok?
Yes, sir.
Yeah. Over to Ashok.
Good evening, all.
One
And then-
minute, one more minute. I just want to give a housekeeping announcement that those who are not speaking, please switch off their audio, mute it, and also please make sure that the questions are posted in the chat box. Thank you so much.
Good evening. I'm very thankful to Dr. Mathew Philip, sir, for giving me opportunity for speaking on this topic. Variceal bleeding topic is of my interest. Before speaking on this topic, I'm also thankful to Dr. Ramesh, who has been constant touch with me for last 1 year. And I am very thankful to Dr. Shibi Mathew and Dr. Phillips. Before starting, we know that variceal bleeding is a common disease which are facing in the patient of cirrhosis, and apart from the cirrhosis in non-cirrhotic portal hypertension also. The most important part is variceal bleeding is very common, and most important, apart from the variceal bleeding, we see that mortality and morbidity also very high. It's a long-term disease which have to be maintained. Not only that the primary treatment for secondary prophylaxis, we also be careful about the variceal bleeding. Next. Next, please. Next, you can progress for this next slide. Yes, Dr. Mathew, please, sir. Next, yes. Before
No, you have to
describing-
tell me next slide. You have to tell me
Yes.
next slide. Okay.
Okay, sir. As we know, hematemesis within the last 24th of the presentation and ongoing melena, or the melanic stool within the last 24 hours in a known or suspected case of portal hypertension. Just we have discussed portal hypertension maybe because of cirrhosis or maybe non-cirrhotic portal hypertension. For example, many patients of pancreatitis where there is thrombosis of the portal vein or splenic vein, there can be portal hypertension. Apart from which, many patients of EHPO can also have the portal hypertension. Now, what is the clinically significant bleed? When there is requirement of more than 2 units of blood or more within 24 hours of time, then it is a clinically significant bleed. The most important points for examination is the systolic BP less than 100, postural change that is more than 20 mmHg fall in BP, or pulse rate more than 100 at the time of onset of the bleeding. These are the points which significant the clinically significant bleed. Next. Now, what is the failure to control active bleeding? In spite of all these, when we are not able to control the bleeding within 120 hours, then it is known as the failure to control. That is the fresh hematemesis after 2 hours after initiation of specific therapy, or in the NJ aspiration tube. If there is more than 100 ml of blood within 2 hours after the start of specific drug or endoscopic treatment, or patient have developed the hypovolemic shock, or they drop in hemoglobin more than 3 grams within 24-hour period. So these are the factors which signify that it is that difficult to control bleeding. The natural history of varices, that is in 40% of patients of cirrhosis, at the onset of cirrhosis, 40% of patients are having the varices, and cumulative incidence over the progress of periods of 10 years is 44%. Now, most important is those patients who are having the advanced cirrhosis, that is child C, mostly patients have the varices, that is 85%, compared to child A, where the cirrhosis is there in child A, 40% patient having the varices. The formation of the new varices occurs at the rate of 5 to 10% per year, and 2 years bleeding rate in the small varices is less, that is 7%. In the high grade varices or large varices, 1/3 of patients have the history of bleed. Overall, 25% of the have the history of bleed. Next, please. Now, the risk stratification for the variceal bleed depending on the HUPG, that is portal pressure, is the very important factor that decide the which group of the varices are having the chances of bleed and which varices have the difficult to control the bleed. So mostly patients who are having the issue of the varices have the portal pressure HUPG more than 10. And when the HUPG is more than 12, these are the patients who have the threshold of bleeding. And those patients who are having the HUPG more than 20, these are difficult to control bleed patients. For gastric varices, the wall tension plays an important role in the bleeding. Next, please. Now, variceal size, the initial classification by the pocket classification, that is grade 1, grade 2, grade 3, depending on the luminal diameter where the varices have occupied. And grade 3 is the most higher risk of varices, where around 50% of the lumen have occupied with the varices. A risk of bleeding increase with the size of the varices. Next, please. So this is the diagram which you see that how the varices are projecting into the lumen, and these patients have increased risk of bleed. Next, please. Now, this is the variceal wall tension. That is very important. Particularly, variceal wall tension is very important in the patient of gastric varices. And rupture of varices related to tension of the variceal wall. And 80% of patients with having the high chances of bleed are having the blue varices, depending on the color of the varices, or cherry red spots are the high risk signs where the chances of bleed are high. Next, please. Now, severity we can assess depending on the blood loss, depending on the systolic blood pressure, diastolic blood pressure, depending on the pulse rate, depending on the respiratory rate of the patient, and mental state of the patient. Those patients who are having the more the bleed, these patients are more likely to develop the hepatic encephalopathy. Next, please. Now, the apostle severity score, depending on the systolic BP, there are certain points depending on the BP. If BP systolic is more than 90, 0 point. If more than 90, but having the postural drop, 1 point. If the systolic BP is less than 90, 2 points. And depending on the child who class A, B, C, there are 3.01 and 2. Next, please. Apart from these two, platelet counts is very important factor. Those patients who are having the low platelet count, more risk of bleed is there. Infection is very important. Those patients, apart from the bleeding, having the infection, these patients' chance of recovery are less. And those who are having the active bleeding at the time of admission, these are also high-risk patients. So minimum score is 0, maximum score is 7. Next, please. So these are the various predictive factors for the fast variceal bleed. Location of varices is very important. Those patients who are having the varices in the upper esophagus, these patients are easy to control and chances of bleed are less. And size of varices, that's we have discussed grade 1, 2, and 3. 3 are the patients we are having the more size and more chances of bleed. And appearance of varices, that is color, depending on the various signs, that is cherry red spots or blue varices. And lastly, variceal pressure, that is the HUPG, it is very important factor. Next, please. Now, there is a univariate analysis, a study from Japanese classification, depending on the patient who are having the bleed. So these are the points just we have discussed. That is location, cherry red spots, size, red well markings, diffuse redness, hemocystic spots, color of varices, and lastly, esophagitis. Those patients who are having the repeated episodes of bleeding or repeated episodes of hematemesis or vomiting, having the esophagitis. This is also very important risk factor. So all these factors we have seen, the 3 important factors which are responsible for the risk of bleeding is the red well markings, size, and cherry red spots, and location. These are the 4 important points where there is significant difference that the risk of bleed is high in this group of patients. Next, please. Now, the screening of esophageal varices. When we have to screen, mostly patients with liver cirrhosis at the time of diagnosis, you should screen for the esophageal varices by upper GI endoscopy. Those patients who are having the compensated form of cirrhosis and having the varices, the recommendation of esophageal endoscopy is after every 1 to 2 years. Those who are having the compensated cirrhosis but without varices, then you can recommend the prophylactic or endoscopy for every 2 to 3 years. If patient having the decompensated form of cirrhosis, annually you should screen by upper GI endoscopy. Lastly, most important factor is the stiffness of the liver. If the stiffness of the liver is less than 20 kilopascal, either by fibroscan or by elastography, or having the platelet count more than 1.5 lakhs, that annual monitoring of these 2 factors is very important. Next, please. Now, how to screen for the varices? Those patients who are having the compensated form of cirrhosis, where there is absent varices or ongoing liver injury is absent, you can recommend or you can prolong the endoscopy period every 3 years. When there is varices absent, but ongoing liver injury is there, then you have to do the endoscopy after every 2 years. When varices are present, depending on the size, whether it is small or large, in small, where there is ongoing liver injury is there, then every year you have to do. If there is small varices, but there is no ongoing liver injury, you can prolong the period of endoscopy every 2 years. When those group of patients are having the medium or large varices, then you have to stratify the treatment depending on whether you have to use the medical or endoscopic band ligation. Medical treatment you can use in the form of non-selective beta blockers, or nowadays there are newer beta blockers you can also use. Endoscopic band ligation is recommended. Endoscopic band ligation should be done until the varices are eradicated, ideally every 2 to 4 weeks. And then after you can recommend every 6 to 12 months endoscopic screening. And those patients who are having the low risk of variceal bleed, that is having the platelet count more than 1.5 lakh and kilopascal less than 20 stiffness, then FRJ endoscopy can be avoided, or these patients may require the ongoing monitoring. Next, please. Now, the primary prophylaxis. The mainstay of primary prophylaxis to prevent an index bleed is non-selective beta blockers or repeated sessions of variceal band ligation. Just we have discussed small varices, but with red color signs or child C, you have to use the non-selective beta blockers. Medium or large varices, either you can use non-selective beta blockers or variceal band ligation. And lastly, propranolol, nadolol, or carbolol, all these can be used as a first-line therapy. Next, please. Now, the general approach in management of the suspected variceal bleed, most important part is the airway protection and volume resuscitation. Restrictive transfusion should be important part. You have not to use the liberal blood transfusion, because more the transfusion, the chances of bleed is also high. And the vasoactive drugs can also be used apart from the blood transfusion. The vasoactive drugs which are commonly used are somatostatin and terlipressin or octreotide, depending on certain complications or conditions where we have to use the somatostatin or where we have to use the terlipressin. And lastly, antibiotic prophylaxis is very important. Next, please. Risk assessment depending on the child to score, MELD score, and HVPG. If MELD score is more than 19, associated with the 20% risk of mortality within the 1 to 2 months. Non-selective beta blockers should not be started in the acute settings and should be stored. That is very important. Those patients who are having the bleeding, who are in the hypovolemia or in the stroke, at that time, non-selective beta blockers should be avoided. Scoring and risk assessment also done because it will identify those group of patients or high-risk patients where early tips can be used as a salvage therapy. Next, please. Now, the urgent management is very important. Once a patient of upper GI bleed or variceal bleed comes to you in the endoscopy room or in your clinic or in your emergency, most important is the orotracheal intubation. Patient presenting with the altered sensorium or hepatic aneuploidy, airway maintenance or airway patency is very important. Second part is at least you use 2 large catheters of 16 or 18 gauge size to avoid to place so that rapid volume expansion can be used. Either crystalloids can be used. Central catheter may be needed for administration of vasoactive drugs. Next, please. So most important point is the volume resuscitation, either with colloids or crystalloids as a first-line treatment. Second, we have to maintain the mean arterial pressure more than 65, systolic blood pressure more than 90, and our target should be to keep the heart rate below 100. And blood should be transfused when the HB drops below 7. And our target should be to keep the HB hemoglobin within 7 to 9. And monitor the HB every 6 hourly for first 2 days, then every 12 hourly for next 3 days. Next, please. Now, this is very important. That restrictive transfusion had lower rebleeding rates and mortality than the liberal transfusion. Just we have discussed. It is not necessary that patient coming with a massive bleed, you have to transfusion 4 or 5 units, because more liberal transfusion will increase the chances of bleed and rebleed more, because it will increase the portal pressure or HUPG more. And there is no recommendation for the use of tranexamic acid or factor 7, which is routine practice in many centers or periphery hospitals. Next, please. Antibiotic prophylaxis is very important because bacterial infection is independently associated with the failure to control bleeding. Antibiotics shown to reduce the bacterial infection and early rebleeding. Approximately 20% patients are infected on the day of admission. Next, please. Which drug we have to use? Common practice is to use the norfloxacin in the dose of 400 milligram twice, or ceftriaxone 1 gram daily for 5 to 7 days. Or ceftriaxone is sometimes better compared to norfloxacin. Those group of patients who are already on prophylaxis for SBP or in advanced cirrhosis, you should be used ceftriaxone in place of the quinolones. Next, please. Now, vasoactive agents. This is very common drug which definitely have the reduction in mortality. Routinely, we use terlipressin, but there are certain conditions where terlipressin should be avoided. Those patients who are having the hypotension or hepatorenal syndrome. And octreotide can be used in this group of patients. And octreotide should be avoided in those patients who are having the hypertension or patient with CRD or peripheral vascular disease. Next, please. Now, duration is very important. It's not completely defined, but usual recommendation is that it should be used for 3 to 5 days to prevent the early rebleeding. In 5 days, hemostasis and mortality is low significantly in those group of patients where the endoscopy therapy is combined with the vasoactive treatment. Next, please. This is a wonderful study that were from the single center, from the AIMS, that 1 day use of telepressin is as good as 3-day use of telepressin. This is study, and most important part is we have to do other data from the multicentric study to validate the study. Next, please. This study shows that 1 day of telepressin is associated with a similar 5-day and 42-day rebleeding rates compared to those group patients who are given the 3 days of telepressin. But is to be validated in multiple center study or double-blind large multicentric studies. Next, please. Now, serum sodium is very important part. Those patients who are not responding, having the persistent hepatic encephalopathy, in these patients, you have to monitor the serum sodium level. Because serum sodium level is very important because telepressin itself causes certain side effects. That is myocardial ischemia can be there, hypertension or cardiac arrhythmia. In many patients, we see the patient is clinically stable, but sudden cardiac death can be explainable because of the LVF as a side effect of telepressin. Next, please. Now, endoscopic therapy, the BAVNO 7 consensus recommends us to perform the diagnostic endoscopy within 12 hours of admission, or optimal timing is to be used within 24 hours after resuscitation with telepressin, antibiotics, or blood transfusion. RCTs have shown that combination of vasoactive drugs with endoscopy therapy is more effective than the isolated use of any therapeutic option alone. Next, please. Now, band versus sclerotherapy, both can be used to achieve the initial control bleeding, but band ligation achieves the higher rate of control of bleeding with lower incidence of adverse events, and combination of vasoactive drugs and ligation as the first option. That is very important. Once you have to do the both, that is endoscopic therapy and vasoactive therapy, combination is the optimal option for the patient of upper GI bleed because of the variceal. Sclerotherapy can be used in certain group of patients when the child of less than 5 years of age, or having the small varices, or those who are having the grade 1 or grade 2, or there is scope is very difficult to post, or patient have already the history of bending because of the repeated session of bending. Sometimes still can also develop. In these group of patients, you can use sclerotherapy as a first line of treatment instead of bending, because it's difficult to pass the bending within the esophagus because of the stricture, or when the child is of the small age, that is 1 year, 2 year, 3 year, or 6 months. Next, please. Now, the management of bleeding gastric varices, again, very important, challenging task. Just we have discussed is the wall tension. That's an important role in the risk of bleeding with the gastric varices. The classification, certain classification, a well-known classification which are following. There are two groups, that is GOV1, second is GOV2, IGV1, IGV2. The therapy of choice in GOV1 is combination of bending plus sinoclate. In GOV2 or IGV1, IGV2, sinoclate is the therapy of choice. Next, please. Now, the recommended therapy, just we have discussed, UV can be treated with the bending or with sinoclate or combination of the both. And nowadays, US is a novel tool which we are using. It improves the achieve the oblation rate and diminish the adverse event, because US guided optimal delivery and the site specific delivery of the glue or coil or gel form or even thrombin can be used in the fundal gastric varices. Next, please. This is a study from our group placed in endoscopy, where we have shown that cyanoacrylate glue injection combined with the coil is a better option compared to the isolated cyanoacrylate injection. So this therapy combination is very useful. The amount is reduced, complications are also less chances of rebleeding. Next, please. Now, BR2 is a newer intervention that we are used by the radiologists, has shown to be effective in controlling the gastric variceal bleed. The most important part, it has certain advantage. It can be performed in those patients who are having the poor hepatic reserve. A retrospective study shows that lower rate of bleeding, rebleeding in BR2 compared to the tips. But mortality difference is not there comparing the BR2 with tips. Next, please. So risk assessment of failure. 10 to 15% of patients have the persistent variceal bleeding or early rebleeding. In these group of patients who are in these group of patients, most important challenging task. For those already having the HUPG more than 20 mmHg, in these group of patients, we have to be careful. Next, please. Now, the management of these high risk of patients, displacement within the first 24 hours. Just we have discussed in initial slides, early tips is very important. It prolongs the survival and lower the treatment failure. But those group of patients, we have to identify for having the child C or having the child B with active bleeding at the endoscopy. Next, please. Now the early tips, more important advantage is the early tips. Most important survival advantage with early tips compared to the control is significant at 86% compared to 60%. So early tips is an important therapy in those patients who are having the high risk of rebleed. Next, please. Now, most important point is difficult to control or failure to control. In spite of all these therapies, in these patients, patient is non-surgical, then tips is definitely a good option. Those who are having the surgical candidate, transplantation definitely provides a good long-term outcome in child B and cirrhosis and should be considered. Tips may be used as a bridge to transplantation. Next, please. A balloon tamponade is a therapy which are used as a rescue therapy when there is massive bleed. It's unable to visualize the site of the bleed or endoscopy is very difficult. In these group of patients, definitely we can plan for balloon tamponade. In balloon tamponade, most important is that we have to inflate the gastric balloon first. And esophageal balloon, if persistent bleed is there, is prevent the bleeding in 90%, but rebleeding chance is high, around 50%. Important complication in the patient is mostly these patients having the hepatic encephalopathy component. So chance of aspiration pneumonia high, ulcer necrosis because of tamponade is high. And in certain cases, that is 5 to 10%, there can be perforation also. Next, please. Next, please. Now, these are the various types of tubes which are available in the market, which are using. The name I will mention that the Linton Neckers tube, Sangston Blackmore tube, and Menostar tube. These tubes have certain difference. Both the tubes and three type tubes, some have the only esophageal suction, some have the both the suction, that is esophageal and gastric, and some have the balloon within the two lumen. There are certain advantages. Most important point is definitely they are a good therapy in preventing the bleed in up to 90% of cases. But once you remove that these tubes, the rebleeding rate is very high. That is 50% of patients. And long-term complications of short-term in the form of ulcer and necrosis is high. In spite of all these therapies, nowadays, in certain cases where we are not able to control, then esophageal metallic stent, that is self-expandable, is an option. It is easily implanted, can be used with or without endoscopy. Diet compression of varices can be done, and oral intake soon afterwards. It can be removed after 7 days. It can also bridge to tips or liver transplant. Next, please. Hemospray nowadays introduced by the Cook in India around 1 year back. It can be used in those group of patients who are having the acute bleeding and those group of patients who are previously have the history of band ligation and post-EVL ulcer. These are very difficult to manage in spite of the glue or thrombin. They are rebleed. In these group of patients, you can use the hemospray. It's not to use routinely, but definitely successful in certain group of patients. Now, secondary prophylaxis, just we have discussed, we can use non-selective beta blockers. The most important point is the combination therapy, that is beta blockers with band ligation. If beta blockers alone is used, there is no recommendation for further endoscopy. EVL protocol, just we have discussed, you have to use the endoscopic band ligation every 2 to 4 weeks till there is complete eradication within 3 to 4 months. Then you can progress or you can have this prolong the duration of monitoring by endoscopy every 6 to 12 months. Tips or BR2 are the first line treatment in the prevention of rebleeding of gastric varices. Once you have done your US or endoscopic therapy, still patients are bleeding. In these group of patients, you can use either tips or BRT. Next, please. So take home message is in the percent of variceal bleeding, primary prophylaxis, we should use non-selective beta blockers or band ligation. That is, in primary prophylaxis, you can use both. In secondary prophylaxis, definitely the combination of the both very important is improve the survival compared to the isolated. EVL should not be used as monotherapy unless there is contraindication for non-selective beta blockers. And non-selective beta blockers should be used carefully in those group of patients who are having the circulatory failure or the shock or having the spontaneous bacterial peritonitis. You should avoid the non-selective beta blockers. Non-selective beta blockers should be introduced when there is circulatory function improved, patient recovers from the shock, BP is good, systolic blood pressure is more than 100, or mean arterial pressure more than 70. Next, please. Next, please. So acute variceal bleeding is an emergency with 10 to 20% of bleeding. And restrictive transplant that we have discussed, we should keep the hemoglobin 7 to 9, and daily sodium monitoring is important in the patients of telepressin. And upper GI endoscopy ideally should be done within 12 hours of admission. And tips of BRTO can be used in selected cases where we are having the cases of failure to control bleeding with our routine endoscopic management. US guidal coil plus glue is ideal for gastric varices, and balloon tamponade or stent can be used as a bridge therapy in those refractory cases of variceal bleed. Thanks, please.
Thank you, Dr. Ashok, for that excellent review of management of variceal bleeding. So the gist of his presentation included the points that we need to remember is that we practice a practice of restrictive blood transfusion. That is the aim of the threshold for transfusion is kept around 7 gram percentage if the patient is non-cardiac. And also we need to do the upper GI endoscopy as early as possible within 12 hours. And also we need to take the help of intervention radiologists at times depending on the clinical scenario. So nowadays, depending on the severity and the risk of bleeding, we are taking the help of intervention radiology for procedures like TIPS and BRTO as rescue procedures. So we will have the discussion at the end of both the topics. So we will be proceeding to the second session today. That is the clinical approach to MASLD. MASLD is a metabolic dysfunction associated steatotic liver disease. As you will be agreeing that metabolic syndrome is considered a pandemic of this millennium. And the previously nomenclature of non-alcoholic fatty liver, this has been changed to MASLD, that is metabolic syndrome associated steatotic liver disease in recent times. So that itself shows the importance of metabolic syndrome. So to talk on all these matters, I invite Dr. Piramanayagam, who is the consultant medical gastroenterologist at Apollo Hospital, Chennai. He has special interests in endoscopic ultrasound, ERCP, therapeutic endoscopy, and GI motility. He has published over 12 original papers and reviewed 15 book chapters. So over to you, Dr. Piramanayagam.
Good evening to all.
Yeah.
Is my slides visible, sir?
Yeah, good.
Yes,
you
yes.
make it a PowerPoint presentation. Yeah.
Good evening to chairpersons, the moderator. I thank the GAPIO ISG for providing me with this opportunity. And I discussed with Dr. Mathew Philip, and he had a very clear mandate that we have to discuss something which is very common. So I chose this topic of fatty liver, what we call as essentially call as a fatty liver. We routinely see this nowadays as a part of our ultrasound report, which is done for some other indication that we come back with a report which says that the patient has a fatty liver. So how do we approach this? In the next 20 minutes, probably I'll give an outline of what is new, what has changed. The terminology has changed from non-alcoholic fatty liver disease to metabolic dysfunction associated steatotic liver disease. What is the burden of fatty liver that we see in India? And why is it important to identify? What is the natural history of this? So how do we risk stratify once we see the patient with fatty liver in the outpatient? And what has changed and what is new in the treatment of this entity? So is it just a new name for an old problem? We'll just see this. When do you call someone as having a fatty liver? By histology, generally a normal healthy liver is supposed to have less than 5% of its mass as lipid content. If someone's liver on the histology has more than 5% of liver mass as lipids, that is excess accumulation of fat in the liver, and that is called as fatty liver. It could be in the form of either macrovesicular, that is big vesicles in the hepatocytes, or it could be in the form of small, tiny little lipid droplets that we see here. So both this are called as fatty liver, but there are distinct causes for both of this. It could be, if it is macrovesicular steatosis, it could be drugs like alcohol or some drugs like steroids or warfarin. Could be inherited metabolic disorders like galactosemia, tyrosinemia, fructose intolerance. Or it could be in association with the metabolic dysfunction, as we are about to see, like diabetes, obesity, total parental nutrition. On the other hand, if we find microvascular steatosis, this is very specific to fatty liver of pregnancy, drug-related Reye's syndrome, like related to salicylate, paracetamol. Moving on. So the earlier definition for non-alcoholic fatty liver disease was that the person should have a fatty liver by imaging or histology, no significant alcohol consumption. And that was defined as less than 30 gram per day in males and less than 20 gram per day in females, and no other good alternate explanation for the steatosis. But this was supposed to be a little restrictive, and there was always a gray area where we couldn't quantify the alcohol intake. So there was always a worry whether it is an alcoholic liver disease or a non-alcoholic fatty liver disease. And that also carried a little bit of social stigma in saying non-alcoholic fatty liver. So, and once we understood the pathophysiology of the accumulation of fatty liver, there was a move towards renaming this as metabolic dysfunction associated fatty liver disease. And the earlier understanding was that there will be from a healthy liver, you have the fat accumulates in the liver, that is the first hit, and beyond which there are certain increased cytokine activation, inflammatory cytokine activation, following which there is not just a fat accumulation, but an inflammation also ongoing in the liver, and which subsequently leads on to collagen deposition and fibrosis. If it is extreme, it is called as cirrhosis. So that was the second hit, which progresses further. And this term non-alcoholic steatohepatitis was introduced in 1980 from Mayo Clinic when they looked at the histopathology reports of 20 people who had not taken alcohol, no significant alcohol intake, but they found histology which was very similar to what they found in alcoholic hepatitis. So this is the current definition or the criteria that has been laid down by a lot of professional societies across the world, where it's a uniform proposed diagnostic criteria for metabolic dysfunction associated fatty liver disease. You should be able to note hepatic steatosis, most often by imaging technique like ultrasound. And if they are overweight or if they are diabetic, that is enough to qualify them and term them as metabolic dysfunction associated fatty liver disease. If they are not overweight or they're not diabetic, they are basically lean, normal weight people without diabetes, then we are looking at the presence of at least 2 of the 7 metabolic risk factors that has been here. This essentially is nothing but metabolic syndrome, what we usually call as metabolic syndrome. They have a waist circumference above the cutoff for different cutoff for Caucasian as well as Asian. Increased blood pressure, increased plasma triglycerides, low HDL, or a pre-diabetic level, or a homo-insulin resistance score more than 2.5, or a highly sensitive C-reactive protein more than 2. These two are new additions to what we essentially would call as a metabolic syndrome. So if you have 2 of the 7 and a fatty liver in a normal or lean patient, that is also classified as metabolic dysfunction associated fatty liver disease. So this is a new definition that has come into role. So what is the estimated burden that we see? Across the world, you find that there's a different proportions, very high incidence of fatty liver disease in the United States and South, in parts of Europe and Asia. India falls somewhere in between, close to 30 to 35%. If you have Indian data, you look at estimated prevalence is about 30%. And the worrisome part is that even in children, it seems to be going up, and the prevalence is close to 12% in non-obese, as well as in obese children, it is up to 2/3. And if you look at hospital-based data, it is 40%. And if it is a community-based data, you see about 30%. So essentially, 1 in 3 adults or even children seem to have fatty liver disease in India. That is a little concerning. Why do I say it is concerning? Look at it, the natural history of fatty liver is such that about fatty liver is from simple steatosis, progresses to inflammation, that is NASH, and then a subsequent scarring of liver, it's a cirrhosis. So this progression can be to the tune of 25% over the next few years, and the spontaneous reversal of NASH is unusual. But a spontaneous reversal of fatty liver to a normal liver is possible in up to 2/3. Once the NASH sets in, about fibrosis progression essentially occurs. It progresses in up to at least 20% of the people in the next decade to cirrhosis. Interestingly, of late, we do find people progressing from steatosis or a non-alcoholic steatosis, hepatitis stage to directly to hepatocellular carcinoma also. And this seems to be more common in Asians as compared to Caucasians. And we all know that once a cirrhosis sets in, it's a ground for development of HCC. Why should we bother about just a fat accumulation in the liver? And this is a nationwide registry in Sweden which brought out a very important data that just the presence of fatty liver, any stage, it could be just here steatosis or cirrhosis, any stage that you look at it, the cumulative events, that is over a period of time, the risk of mortality is definitely higher in any stage of fatty liver disease. And if you sub-classify, you find that even simple steatosis also they seem to have higher cumulative events and higher risk of mortality. And this is definitely higher when there is a stage of cirrhosis. So what causes this extra mortality, additional mortality in patients with fatty liver? Excess mortality initially was thought of mainly because of the cardiovascular disease. But of late, we do find that primarily due to increased extrahepatic cancer and cirrhosis. Once it is a little far advanced fibrosis, we find that cirrhosis-specific mortality adds on to it with modest contribution from cardiovascular disease and specific hepatocellular cancer. So what is worrisome here is that there is increased chance of extrahepatic cancer, which contributes to the mortality. And most common cause of mortality in patients with NFLD without advanced fibrosis is still cardiovascular disease and non-hepatic malignancies. Once significant or advanced fibrosis sets in, it's a death from liver disease which determines the course. So what do we call as advanced fibrosis? Patients with NASH and stage F2 to F4 of fibrosis are called as high-risk patients. So these are the at-risk patients who are likely to progress to significant cirrhosis. So how do we risk stratify? A patient who comes to us walks into our OP. It is just an example of such a patient, a 46-year-old gentleman who is known to have diabetes, dyslipidemia in the last 10 years, has been on treatment for that, has ethanol intake for about 20 grams per day, is obese, and he has hepatomegaly on examination. Carries with him an ultrasound report says grade 2 fatty liver. Once we do basic blood workups, we find that hemoglobin platelets are all good, except the little low platelet counts, but ALT AST is 56/44, nothing too much, but it's mildly elevated. And HbA1c is 8.8, triglycerides are high. So looking at it, we'll say, okay, this gentleman has diabetes, obesity with metabolic dysfunction associated fatty liver disease. Here, the presence of ethanol intake does not exclude a coexistent metabolic dysfunction associated fatty liver disease, though here the ethanol intake is less than what is classified for alcoholic liver disease. But how do we identify these patients who are likely to progress? Quite a few patients may not progress. There are certain patients who are going to progress. The gold standard would be a liver biopsy. But that is too invasive for a patient who has not yet had any symptoms, and many people are not likely to consent to undergo a liver biopsy. So there came the interest of using non-invasive modalities. Some are blood tests and some are imaging features which have come up in the last couple of decades. So this would be the classical liver biopsy where you see histological changes. It's only steatosis. In this, you see inflammatory cells coming in and crowding the hepatocytes. And here you see cirrhosis of collagen deposits around the lobules. So there are certain specific scores which have come up called as a non-alcoholic fatty liver activity score and histological findings, which will show perisinusoidal fibrosis to begin with, which subsequently becomes periportal and portal fibrosis, where it becomes a complete cirrhosis. So F1, F2, F3, and F4. F3 and F4 is considered for advanced fibrosis. Is there a way, in the short of liver biopsy, we can use in the primary care setting certain simple blood parameters with age, which can be used to determine who are at high risk. The most accepted one is what we call as a FIB4 score, where it uses only about 4 parameters: age, ALT, AST, and a platelet count. And if you key in this into this online calculator, it will give you a FIB4 score. So how do we interpret this? If a FIB4 score is less than 1.3, then they are at very low risk for progression to cirrhosis, so that can be managed at the primary level. The main aim would be to manage their lifestyle and diet and treat the comorbidities and reassess in about 2 to 3 years. But if the FIB4 score is more than 1.3, then we probably will have to refer to a higher center for further evaluation as to whether they are going to progress further. But there is a limit here. It is not very accurate in old or very young people. And there are other proprietary serum markers, which probably is not widely available in India, but I think fibrous test is available in certain places. But all this is useful for looking at extremes of patients where they are going to progress to liver cirrhosis. So these are all non-invasive scores which are available in the world and some available in India also. So these are blood-related parameters. There was more interest in looking at how stiff the liver has become by either use of ultrasound waves or somewhere where we can measure the velocity with which the shear waves go. So if the liver is very stiff, they are likely to be transmitted very quickly, and indirectly you will be able to assess how stiff the liver has become. The most popular one is the is a vibration-controlled transient elastography with the proprietary name of FibroScan, which is nowadays widely available in India, where we can determine, and the value it gives us in the form of kilopascals, which tell us how stiff the liver has become. The other thing is more quantitative would be an MR elastography, but that's very limited. It is a very good assessment of both the fat and the fibrosis, but it is limited by the availability in India, and it's quite costly too. So this is the way it is interpreted. So what is the proposed algorithm for risk stratification? You use your FIT4 score. If it is low risk, we can manage at the periphery. If it is indeterminate or high risk, then you use a second test like a vibration control elastography. If again that shows low risk, you can reassess in 2 to 3 years. But if you are at a high risk of progression, these are the ones with at-risk fibrosis stage, then you refer to a gastroenterologist. Let us say in this case scenario that we just brought out, the patient had a FIB4 score of 2.4, that is more than 1.3. So he undergoes the next step, that is a FibroScan evaluation, which again shows it's a very high, like 16 kilopascals. Anything above 12 to 14 kilopascals is considered or equivalent to a cirrhosis or F4 fibrosis. So even though the patient is not symptomatic, we find that the patient already has progressed to a state of advanced fibrosis. So he has diabetes, obesity with all the risk factors, with metabolic dysfunction associated liver disease with advanced fibrosis. So how do we go about treating it? What is the treatment available? The most important thing, again, is more often than not, we look at how to manage his risk factors. The weight loss, diet, exercise, and finally comes the medication. Quickly, if you have to look at weight loss, if you have more than 5% weight loss, then it improves the steatosis rate. If you can achieve more than 10% weight loss from the baseline, it definitely improves the inflammation and fibrosis. But the practical aspect is that less than 10% of patients who specifically go on a diet or exercise are able to achieve an effective weight loss at 1 year. So this also is not just about writing a prescription and telling them or giving a diet chart. You need a multidisciplinary approach where you also include behavioral medicine specialists, dietitians, and that will help because sometimes obesity is secondary to overeating or a tendency to overeat. I think that needs some behavioral medicine specialists. And also, you have to look at the macronutrient composition. We advise them to decrease the saturated fat, refined sugars, or sugar-sweetened beverages. And all the types of diet which have been used, like low-carb diet, Mediterranean diet, low-fat diet, and certain intermittent fasting for certain people achieve comparable results in improving the NFLD. Interestingly, 3 cups of coffee has also shown to reduce the risk of advancement of liver fibrosis. Physical activity definitely improves. At least what is recommended is 150 minutes per week. And if they are already exercising and increasing the physical activity by 60 minutes a week is recommended. And they should not be looked at only in the form of weight loss, how much they achieve. Exercise also has significant cardiometabolic benefits. So even if they don't lose weight, we should encourage them to continue to lose weight. And you can titrate the intensity of activity according to the physical ability. Coming to the last part, what is the pharmacotherapy? Have we got any medicines which are definitely proven to improve this fatty liver disease progression? So there are many drugs which have been used long term. I mean, many of us do use still this ursodeoxycholic acid, vitamin E, pioglitazone, metformin. All this have been attempted in patients with NASH with or without diabetes. But none of them have been given an FDA approval for use in specifically NASH. That is because it is not shown to improve the fibrosis stage. None of these medicines have shown to improve or reverse the fibrosis. So they are improve the steatosis content. They seem to improve the biochemistry, but and some of them seem to improve the inflammatory aspect or NASH scores and NASH scores, but none of these drugs have shown to reverse or improve the fibrosis. So now that we have known much more about the mechanism by which it is going, there is no molecular related ones like a PPR, alpha, gamma, agonist, which can be used, that is saroglitazar, which is interestingly has been manufactured or has been developed in India, and it has been approved by the Drug Controller of India for use in NASH. It has shown to improve the non-alcoholic steatohepatitis score, but whether it improves fibrosis, we need lot more data. It seems to have some surrogates where we see that it improves the fibroscan readings, but whether it really improves on the histology is something that is still awaited. So FDA has not yet approved as it. Obeticholic acid has been approved for primary biliary cirrhosis, but has not yet gotten a FDA approval for use in NASH. But interestingly, it is shown to, in 1/3 of patients, it seems to improve the fibrosis score. But the downside to it is that there are a lot of pruritus, increased incidence of gallstones. There's another new drug, FGF1 analog, which has completed phase 2 trial, which also seems to improve the fibrosis score. The one drug which has got an FDA approval this year is resmetirom. It's a thyroid hormone receptor beta agonist, which has shown about significant improvement in the fibrosis stage also. And there are other two very promising drugs, tirzepatide and survodutide, which are only in phase 2 trials, which are GLP-1 GAP agonists used in the management of diabetes, which seem to improve in up to 40 to 45% of patients with fibrosis. But as yet, they have not achieved any FDA approval. So coming back to the treatment plan for the patient who is discussed, we would encourage him to avoid alcohol. We provide him a dietary plan with a multidisciplinary team, and also encourage him to do exercise 30 minutes, at least brisk walk per day for 5 days per week. To consider saroglitazar, since he has a hypertriglyceridemia, which can be improved with triglycerides for diabetic triglyceridemia as well as for fatty liver. And if his cost is not an issue, we may try thinking of adding a tirzepatide, which can improve both the diabetes as well as the fatty liver. And resmetirom, definitely when it becomes available in India, but it's likely to be quite costly when it becomes available. And we should also consider giving primary prophylaxis for cardiovascular events and an age-appropriate screening for extrahepatic malignancies. I think to summarize, you identify patients at risk. If the patient is diabetic, 2 or more cardiovascular risk factors with steatosis, metabolic risk factors or steatosis, then we know that he has a fatty liver disease. You do a non-invasive screening with the FIB4. The FIB4 is less than 1.3. They're unlikely to have significant fibrosis, so they can be managed with their family medicine doctor. They take care of their diet, exercise, and the comorbidities. If anywhere above 2.67, they are likely to be fairly advanced fibrosis, so go refer to a hepatologist. Somewhere in between, you use the liver stiffness measurement based on fibroscan or MR elastography, and then they can be referred if they have a high fibrosis score. What do we do if they do have, as of now, they have low risk or patients like FIB4 less than 1.3 or very low liver stiffness measurement? Their treatment right now is mainly lifestyle modification, weight loss, and right now no pharmacotherapy. But if they are high-risk patients, as I said, F2 or F4 fibrosis, then in addition to lifestyle and weight loss, there is a role for pharmacotherapy to be used. And more importantly, we should be screening them for cardiovascular and extrahepatic malignancies also. And thank you all for providing me this opportunity. I'll be happy to take questions.
Thank you, Dr. Piramanayagam, for that wonderful overview. I think you have touched almost all the practical aspects of managing MASLD. Let me ask you one question. If a patient comes to your OP with now the whole population is actually worried about fatty liver. So the patient comes to you with the fatty liver, just fatty liver. He doesn't have any metabolic risk factor, maybe only one. How will you counsel that patient? Will you do elastography or non-invasive markers, or will you keep the patient under follow-up?
Well, I just touched upon it. If it is only probably I will do a liver function test to see what is happening to his liver enzymes. That gives us some idea as to whether there is some inflammatory activity going on in the liver. We will also look at the metabolic factors, and whenever a patient comes to us with a fatty liver, I think that is an opportunity for us to screen them for diabetes, dyslipidemia, obesity, blood pressure, thyroid. I mean, I would generally look for a simple panel of liver functions, sugars, thyroid, lipid profile, and look at his weight and the presence of blood pressure. So this gives us an opportunity for us to see if he has any of those metabolic risk factors. If you said if there's only one risk factor, then probably I will address that. I will reassure him that it is unlikely to be anything worrisome, but we need to follow it up at a periodical, at a specific period as he comes forward, depending on his comorbidities. But having said that, we also have to impress upon him that the need that if he doesn't attend to it at this point in time, there is a small risk of progression to inflammation or fibrosis. But right now, at this stage, probably I wouldn't be asking for any of the other tests.
Yes, I agree with that. So in the metabolic syndrome is increasing. So maybe because of the lifestyle, I mean dietary habits, lack of exercise, etc. So do you think that in the next 1 or 2 decades, the cirrhosis related to MASLD, will it overtake other causes of cirrhosis?
I think so. I mean, pretty much in India, I think India has already become the diabetic capital, I believe. So we are heading to a stage where the proportion of patients with liver disease due to metabolic dysfunction is going to skyrocket. But again, we'd also have equally important problem of alcoholic liver disease. So I think they both go hand in hand in India till the time government comes in with some plan to control the alcohol. Which I think these both so the viral part has already come down. I think to a fair extent with the immunization and blood bank screening practices. So I think alcohol and metabolic dysfunction associated fatty liver will become more. And in some of the transplant centers, the data is coming up where they find that most of the transplant is being done for metabolic dysfunction associated fatty liver disease cirrhosis.
Dr. Ramesh, can you take up questions for Ashok, Jhajharia, and both the speakers did very well. And we have only 5 minutes more, so take up questions very fast.
Yeah, excellent talk, Ashok, Dr. Ashok and Dr. Piramanayagam. I have a few questions to Dr. Ashok. One is, in the case setting of ascites, will you use beta blocker, or if so, which beta blocker you will prefer? And the second question is, in emergency setting, in a clinical emergency ward, how will you differentiate variceal and non-variceal bleeding? And one more question, can I give now?
Answer those questions. After that, we can.
Okay. Third question is, in PPA, most of the upper GI bleeding, we will use PPA. Is it beneficial, or any recommendation on that? So
You are mute. You are mute. Ashok, you are mute. Jhajharia, you are mute.
If Dr. Ashok is not there.
Ashok is there, but he's mute.
Okay.
Still mute.
Yes, sir.
Yeah, now you can take.
In the patient of cirrhosis and portal hypertension, these patients have high risk of spontaneous rectal peritonitis. So ideally, PPI should be avoided. Routinely, they should not be used routinely, because nowadays there are many studies where the risk of spontaneous rectal peritonitis is very high in those group of patients who are on the long term of PPI. So in patient of cirrhosis, where CTP class B or C, even in A, routine use of PPI should be avoided because it definitely increases the risk of SBP. Second, which beta blocker should be used? Nowadays, there are many studies where carvedilol seems to be certainly superior compared to the propranolol. So that is, carvedilol should be used in most of the cases. In certain group of patients where patient is from a trusted center or from a poor socioeconomic status, then we can use propranolol. It is also as good as, but certain studies show that carvedilol seems to be superior compared to the propranolol.
There's another question, clinical question. A patient in the emergency room coming with upper GI bleed, how the general and the doctor, emergency doctor should, what are the clues to find out whether it's a variceal bleed or it's a non-variceal bleed, like peptic ulcer?
Most important point to differentiate is presence of ascites. Because patient coming with the ascites, coming with the altered sensorium, having the jaundice, having the bilateral edema feet, there are certain clinical features or there are certain signs which show the patient having the underlying cirrhosis, underlying portal hypertension. Most important is the presence of ascites. Second, having the jaundice. Third is having the bilateral edema feet. And third, lastly, is sensorium is altered. In these group of patients, there are chances that the variceal bleed is high. In certain group of patients, where in spite of this absence of these, in patients of pancreatitis also, left-sided or segmental portal hypertension can also be there. That can also be source of variceal bleed, that is gastric variceal bleed, more in patients of pancreatitis, where you have to differentiate whether patient having any history of pain, severe pain, radiating to the back, repeated episodes of pain, pain aggravating in last 1 month, 6 months, or multiple episodes of acute abdomen. In these patients also can have the portal hypertension. So by clinical examination and history, you can differentiate whether it is the variceal bleed or non-variceal bleed.
So basically, it is actually look for evidence of chronic liver disease and also for palpating for spleen in patients with the portal hypertension. In
Yes,
other
sir.
words, in a patient coming to the casualty and is omitting blood, if the spleen is palpable, it's very likely that we are dealing with a portal hypertension bleed. Is that right?
Yes, sir.
Yeah. Oh,
Next
one more
question.
question. One more question, Dr. Ashok. How long
Yes,
you
sir.
will use antibiotic in a variceal bleeding? How long you will use?
How long?
You will use antibiotics in a
Antibiotics. Most important part is that initially the recommendation was that those group of patients who are having the SBP, definitely we have to use the long-term prophylaxis. Those who have no history of SBP, then 7 to 14 days antibiotic is sufficient. Nowadays, initially we were using the cefotaxime, but nowadays where we are certain studies where MRS spectrum is very common, in this group, the antibiotic sensitivity or the use of antibiotic choice have changed. Nowadays, we are using linezolid, we are using the ceftriaxone, or we are using the MRS spectrum of antibiotics, either IV or oral. But mostly in the absence of SGP, the duration of antibiotics 7 to 14 days is sufficient. Unless there is SVP, then you have to use the long-term prophylaxis.
yeah.
Shall I ask?
Dr. Shibi.
Previously, we had a practice. I think many of us had the practice of putting a Riles tube to the patient, whoever comes to casualty with upper GI bleed. So, as per the current guidelines, do you recommend this, Dr. Ashok, please?
This is initially not recommended, but we have seen in our long-term many of patients with cirrhosis, because those patients who have the bleed, after the bleed on the esophageal varices, there is a certain point where the bleed has stopped, there is certain clot, or we can see there is bleeding has stopped. If you put the Riles tube, there are high chances that the Riles tube will touch the site of the bleed or nearby varices. So chance of bleed is high in the patient of portal hypertension. In non-portal hypertension, non-variceal bleed, Riles tube can be used when there is source of bleed is from the gastric or duodenal ulcer. But in presence of variceal ulcer or variceal bleed, you should avoid. But in group of patients where having the HE, that is hepatic amyloid grade 3 or 4 unconscious, we should use the Riles tube.
Yes, I agree with Dr. Ashok that Riles tube may be reserved for a certain group of patients. Also, it is seen that if you put the Riles tube, the chance of micro aspirations are high, and the chance of infections related to cirrhosis are also high. So, as far as possible, Riles tube should be avoided in these cirrhotic patients with the variceal bleed.
Piramanayagam, now we see many patients with a combination of alcoholism and MASLD. So how do you address this issue? How will you actually know that what really caused the cirrhosis? And another question is, many patients with fatty liver also, they ask, can we have at least some drinks sometime? What will be your recommendation?
Okay, sir. So coming to the first question, differentiating how much alcohol contributed or how much of it is related to the metabolic dysfunction is quite difficult. If there is a significant alcohol intake, both can cause concomitant injury to the liver. That is what we understand. So that answers to the second question, where we have to be telling them that when you already have a fatty liver, there is nothing like a safe amount of alcohol. So it will be preferable that they avoid alcohol intake. As of now, whatever recommendations are, less than 20 grams per day, less than 30 grams per day for significant liver injury. But these patients already have a fatty liver, so I don't know if the same alcohol levels will apply for them.
In other words, there is no safe limit for alcoholism, and especially for patients with even this is true for normal people, but especially for fatty liver, I think, any amount of alcohol could be deleterious, though we don't have any true data on that. So
Yeah.
I think
Metabolic syndrome, the combination of metabolic syndrome with the non-cirrhotic range of alcohol intake, that is a dangerous combination.
Yeah.
Even with the non-cirrhotic range, those with the metabolic syndrome, the risk is very high, I feel.
I think need to conclude, and Shibi and Ramesh, your final comments, and then we'll conclude.
Yeah, too interesting, very useful session, and it's a practically, clinically oriented session, sir. And I think it's a useful session, and basic points are touched, and both speakers cover in depth. I don't think that there is a problem in managing variceal bleeding or a NASH or a MASLD after this lesson. So it's excellent talk, useful talk.
Dr. Shibi, please.
Both the speakers have done a great job. I feel both the talks were great. And on behalf of IST and GAPIO, I thank both the speakers and the audience for their active participation. Let me also thank Dr. Mathew Philip and Dr. Ramesh for being part of this program and for your valuable inputs as well. I also thank IST and GAPIO for providing such a great platform and conducting the program today. Thank you all.
Anybody from GAPIO want to say something? Jitendra?
Jiten Malik sir, thank you so much for the for your talk, sir. Dr. Piramanayagam and Dr. Ashok sir, and thank you so much, Dr. Shibi and Dr. Mathew, for taking this session forward, sir. Many thanks, sir.
Yeah, once again, I thank the speakers, Piramanayagam and Ashok. They're all busy people, and having spent their time for this wonderful session, excellent talk. And Shibi and Ramesh, all are very, very busy people now. And they spend their prime time for this discussion. Thanks a lot. And thanks GAPIO and IST for making this platform so useful, especially not only for gastroenterologists, but also for a non-gastroenterologists, where these diseases can be dispersed and actually sharing of knowledge into the non-gastroenterology forum as well. Thank you so much. We are signing off, and good night. And in some places, other part of the world, maybe good morning. Okay, then. Thank you so much.
Thanks.
Thank you.